submitted and reviewed. So it is now my pleasure to introduce you to Dr. Anupama Tiwari, Assistant Professor of Medicine in the Division of Pulmonary and Critical Care and Sleep Medicine at Albany Medical Center. She's also the director of their post-COVID care clinic. Dr. Tiwari specializes in treating adult patients with interstitial lung disease, sleep disorders, and long-term issues related to COVID-19. She also cares for patients with asthma, COPD, sarcoidosis, and other respiratory disorders.
The probate issue, I was hoping that you could refer me to somebody who could help answer some of my questions.
Hang on. So without further ado, please welcome Dr. Tiwari.
Yes.
Okay, well, thank you for that warm welcome, Joanne. Appreciate it. And thank you, Kelly, as well. Both of you have been fantastic helping set this up. And I'm going to be talking to you about post-COVID syndrome. And there's quite a diverse, group that I'm speaking to. So, I'm trying to cater to the needs of those who are from the medical background, as well as those who probably are not professionally in the medical background. So, so what I'll try to do is keep it simple, but also there are, areas where I have used some medical terminology just to make sure that everybody feels like they're getting something out of this talk. There are going to be a lot of slides that I'm not going to read, but they're going to be part of your packet so that later on, if those who are interested in reviewing more details about this, then they can actually look at those slides or look at those websites for additional information. So the disclosures have already been mentioned, and the objectives of the talk, we're going to start with seeing what are we trying to achieve in the next hour or so here. So we want to recognize the symptomatology of post-COVID syndrome. We want to be able to identify who are the people who are at risk for developing post-COVID syndrome and how to initiate an assessment of post-COVID syndrome. We also want to understand that how relevant and important a multidisciplinary approach is involved in the recovery of these patients. And then when do we need to initiate appropriate referrals? So at this point, I think we want to do a quick poll. We have everybody online here. So if Kelly, you want to go ahead and launch that. There are going to be 2 questions, I believe.
Yes, we have 2 questions, and despite preparation, the polls have disappeared from my screen. So Joanne or Stephanie, I want to.
Yeah, I've got them.
Perfect.
Stephanie, do you have them?
I do. Answer.
Can everyone see the polls?
I can, yeah.
Yeah, we've got 11 answers so far. You can't see them, Kelly?
No, they're not popping up on my screen for whatever reason. As long as everyone else can see them, that's fine.
Can we move on to the next one?
That's a good one.
We apologize. We've tested this several times prior to today's session, and of course it worked fantastic, all the practice sessions.
All right. So yeah, I think that's what I saw. Can I go ahead with the answers, or can we? Yeah, so everybody's heard of long COVID, this term, before coming here, and that's great. And the second part was, do you know of someone? So we have about 54% saying that they don't know of anyone, but 46%, it's almost like a 50-50, even though the 54% said no to knowing someone suffering from long COVID, but at least 46% know of someone who has suffered from long COVID. Thank you, and we can move on now. So I'm going to get the next slide to move. So I'm going to, this is a little bit of a background about COVID, which we are familiar with. So we know that COVID-19 pandemic was announced in March of 2022 by the WHO. And up till now, this number keeps changing, obviously, all the time, but about 644 million cases have been reported, with about 6.6 million deaths. The spectrum of the illness can vary quite a bit. You can have patients who are asymptomatic, or you can have people who have mild disease to severe to be, or sometimes even critically ill to be admitted in the ICU. The overall case fatality rate in terms of how many would die from this illness is about 2.3%. So here's a percentage of breakdown of the spectrum of the disease. Majority of the individuals are going to be asymptomatic and have just mild disease, about 80 to 85%. And then there are some who will end up developing severe disease that requires hospitalization or oxygen supplementation. And that is about 10 to 15%. And then we have individuals who end up being in the ICU, and that's about 5% or so. Most people do recover completely within 4 weeks, 3 to 4 weeks. So then we talk about the definitions of what is acute COVID, what is post-COVID, what is long COVID. These terms are so much all over the place. And honestly, there's no perfect definition, and there are different sources quoting different definitions, but here's one way to understand this. So acute COVID-19 is when someone has signs and symptoms of COVID-19 infection that lasts for up to 4 weeks. So, 4 weeks is sort of understood as the amount of time someone might take to fully recover from the illness. And then there are individuals who have ongoing symptoms even beyond 4 weeks. And that is known as ongoing symptomatic COVID, or also long COVID or chronic COVID, which means beyond 4 weeks till up to maybe 12 weeks. So 1 to 3 months. They are having persistent symptoms, and these individuals are called long COVID. And then if the symptoms are definitely lasting beyond 3 months, at that point, some places are calling these individuals as having the post-COVID syndrome. So a lot of terms here, but I think in general, the general concept is if you're having symptoms, I think beyond 3 months, I think in general, but that's really the time when you would start thinking about post-COVID syndrome, chronic COVID, long COVID, post-acute COVID sequelae, that's another term for it. And, so I think you have to start considering that when you see someone with those symptoms. So what are these symptoms? We have this slide here that depicts very nicely different organ systems that can be involved in post-COVID syndrome. So starting from top, we have the neurological system that can be involved, in which brain fog is a very, very common symptom that we see people come to our clinic with. They can have loss of smell and taste. They can also have stroke or confusion. They can have, in terms of psychiatric symptoms, depression, post-traumatic stress disorder, anxiety, and obviously triggered by social isolation that they experienced in the acute illness. Pulmonary system-wise, shortness of breath or dyspnea, cough are common symptoms. They can have persistent chest pain. They can have ILD or scarring of their lungs from acute COVID-19. In the cardiovascular system, they can have palpitations, heart racing, feeling of skip beats. They can have inflammation of the heart, the covering of the heart, which is known as myocarditis and pericarditis. They can even manifest as heart failure. You can also have skin involvement with rash, and we're going to go in a little bit detail about all of these systems in the subsequent slides, where you might be able to see some pictures to appreciate these symptoms even more. So they can have a rash, they can have something called as COVID toes, and then fatigue and myalgias, which is like muscle aches, joint pains, even neuropathy and numbness, tingling sort of in their extremities can also be a manifestation. Now, this looks like a busy slide, and it's just to keep it in your packet for those who are interested in knowing which symptoms and what proportion of people experience those symptoms and how long do those symptoms last. So for example, the common physical symptoms listed here are fatigue, dyspnea or shortness of breath, chest discomfort, cough, loss of smell. So you can see majority of the patients, 15 to 87% of patients will have fatigue, and it does take at least 3 months for that to get better. So I'm just going to leave this slide in case somebody is wanting to look in more detail about what is the proportion of people affected by these symptoms and how long it takes for these symptoms to resolve. This one is a little bit simpler graphic to look at, which again shows us the 10 most common symptoms in patients with COVID-19. So you have fatigue, again, dyspnea being shortness of breath, myalgias, muscle aches, cough, headaches, joint pain, chest pain, altered smell, diarrhea, and altered taste. And so we can see here that what is the prevalence of these symptoms from top to bottom. And we can see the top three symptoms being fatigue, shortness of breath, and really just feeling of weakness, myalgias, muscle aches. So let's talk a little bit about the pulmonary system and what kind of manifestations we can see. So the first, and this is what we are experts in our clinic. I'm a pulmonologist, so this is kind of why we see a lot of these patients referred here for evaluation of. And so the one possibility when I see somebody in clinic with symptoms of shortness of breath or cough, I'm wondering if they have something called as post-COVID interstitial lung disease, or basically lung scarring. Other possibilities include, could they have a COVID pneumonia which hasn't resolved fully? And there are special terms for this, such as organizing pneumonia. They can even have blood clots in their lungs, called as pulmonary embolism. They might even have exacerbation or flare-up of their underlying lung problems, such as asthma and COPD. In terms of their evaluation, they would get a breathing function test when they come to our office. And then we also can do an imaging study like a chest X-ray or a CT scan if needed, depending on each individual patient. So here's a scan of a normal lung, how this looks like. And I just wanted to show you a few pictures of the lungs of COVID patients that we have seen. This is what a normal CT scan looks like. So this is as if like, you have a bread loaf and you're slicing through the bread loaf from top to bottom. So this is like a slice of the lung. So one is the right side, the other is the left side, in the center is the heart. And the normal lung is supposed to somewhat look like this. And the white stuff is the blood vessels in this black area, which is essentially normal. This is the front, and this is the spine area, which is the back. So in a person who has post-COVID syndrome, the lungs actually end up looking like this. I mean, I think we all can, even though we're not experts, but I think we can really appreciate that the amount of lung involvement can be quite severe. And this is in an acute part of the illness. This is actually how a COVID pneumonia would look like. All this white, stuff that you see basically in the background of that black is how pneumonia would look like on a CAT scan. And then on the slide, that is the panel B, is where the same individual has been imaged 6 weeks later. And you can see that the fluffiness is sort of gone, but you're still seeing, leftover disease. And that's known as the scarring that has persisted in this person. So this is how a COVID pneumonia can evolve afterwards, after an acute illness. There's another example of another individual. This is also someone who had COVID pneumonia, and then they were imaged about 8 weeks after discharge because they had persistent symptoms. And you can see that over here, again, these opacities are persisting. And then there is in the different cuts of the same image, basically showing you how things have evolved. So again, just to kind of give you just a glimpse of how these lungs could look like over a period of time. I'm moving on to now cardiac abnormalities. And in this situation, you have these are the possibilities someone can have. Someone can have inflammation of their heart. So in a group of 26 college athletes, when they did an MRI of their heart, 12 to 53 days after the acute COVID infection, that they found that in the 26 of those individuals, at least 12 of them had myocarditis, or the inflammation of their heart. Then pericarditis is inflammation of the sac around the heart. That was also seen in about 40% of patients in a study after 70 days of infection. So even after 2 months, people can have these manifestations and findings. Then there's another manifestation in the cardiac system, which is known as POTS, which is the postural orthostatic tachycardia syndrome, in which people can have accelerated heart rate when they stand up from a sitting position. So anytime there's any postural change, their heart rate would go up. And so that is also very distressing to many people after fully recovering otherwise from the COVID infection. Moving on to the neurological abnormalities, as already mentioned in the first slide, they can have headaches, they can have brain fog, they can have loss of smell and taste, and that can really affect the quality of life in these individuals. You might think that loss of taste and smell may not be a big thing, but ask those people who have had no taste and smell for 2 years now, and they come in really distressed about these symptoms. Of course, inflammation of the brain can manifest as confusion, memory problems, things like that, and seizures and stroke have also been found to be present in these people. In terms of psychological burden of the disease, now that's also a big area to focus on. They can have anxiety, depression. There's so much social isolation that many of them have experienced in the early part. There can be something called as a post-traumatic stress disorder because of not having their loved ones near them when they were acutely ill. They're isolated, they don't have access to care. There's not much known about the disease. There's a lot of fear about what may end up happening, how their lives are going to end up happening. So all of this, in addition to whatever else is obviously happening in other organ systems, can happen in these patients. Many times they might have recovered fully from the acute illness, but their quality of life is still reduced because of many reasons like mood impairment, sleep impairment, not being able to do the things that they normally could do before easily. So here's some pictures of the skin involvement that we were talking about. And, you know, this is, I'm not going to read every line in the bottom, but these are basic. This is someone who had psoriasis, and look how there's, you know, psoriasis lesions kind of flared up. This is the COVID toe that we talk about many times. And then these are some special, you know, lesions known as erythema multiforme that can be seen on their, this is someone's feet where you can see these kind of lesions after a COVID infection. So basically, post-COVID symptoms in different studies have been noted in different contrasting frequencies and durations, depending upon where the study was done, at what time it was done, and what population was looked at. It is more likely to occur, however, after more severe illness than after mild illness. It has been more commonly reported among unvaccinated people more. And sometimes people may have these symptoms, but may never have known that they had an acute COVID infection. So they might not have tested positive, or they were asymptomatic. And so they never actually went ahead and, you know, got a test because they never had any symptoms. But later on, they start having multitude of symptoms, but there's no positive test because initially they were asymptomatic. So like I said, the percentage of these percentages are different. What is written about how common these symptoms are, depending on where you look at. These percentages that I have on this slide are from the CDC data from 2022. So they are saying that about 13% of people will have persistent symptoms at 1 month or longer. 2.5% will have symptoms at 3 months or longer, but this number is different depending on where you look at. But definitely if they were hospitalized, then 30%, a third of patients will continue to have persistent symptoms, at least even 6 months after their hospitalization. So is there any criteria for diagnosing long COVID? So there is no published diagnostic criteria, but what is important is to know the history and the time course. So when they actually developed COVID, acute COVID, and afterwards, what is the time course of their illness? That is the key thing. You have to sometimes exclude other possible diagnoses that could resemble post-COVID syndrome before you call it post-COVID syndrome. So now I'm going to shift gears and just talk real quickly about what are the risk factors or predictors of who we think can develop long COVID. So if in this particular nice picture, you can see there's a summary of all the factors. So the older the individual is, the, and the more comorbidities they have, higher the chances that they will have persistent symptoms afterwards. If they were hospitalized, they were requiring ICU stay, looking at some of their lab markers, that could also signal us in terms of who would end up having long COVID. And then some of the miscellaneous factors, in which I especially want to mention the middle-aged females. These are the ones who have been found to actually have in studies higher post-COVID syndrome frequency. And then if they had multiple symptoms initially, so if they had more than 5 symptoms during the first week of infection, these individuals tend to have long COVID afterwards more commonly. Underlying comorbidities could be ranging from diabetes, hypertension, obesity, cardiovascular disease, smoking, alcohol, kidney disease. All of these would put them at a risk for developing long COVID. And then vaccination status, again, as mentioned, unvaccinated individuals have been found to have higher chance of long COVID syndrome. And the disadvantaged communities are also found to have a longer risk or longer possibility or probability of having long COVID syndrome. So why does this really happen? I think that is also a very good question to think about, something that is being studied quite avidly in the scientific community, but not fully yet clear. But if I want to just briefly mention one area where we think why we think this happens is because of the excessive inflammatory response that happens in the body after the viral infection. And that really takes a long time to recover. That is taking sometimes in some individuals longer to get better than others. Now, there are other multitude of factors that could be there, which I'm not going to read right now, but essentially could be because of an aberrant immune system response that can happen in response to the viral infection too. These individuals are also at a higher risk for readmission. And so in one study, people, 15% were actually re-hospitalized within 8 weeks. So if you have persistent symptoms after being discharged, then the risk for rehospitalization is also much higher in these individuals. Now, this is a busy slide that is just going to be in your packet for just to let you know that there are other conditions that are similar to long COVID that we need to be aware of. And so one of them is the myalgic encephalomyelitis or chronic fatigue syndrome. We might have heard of that term more commonly. And then there's also mast cell activation syndrome and POTS. These are other conditions that can resemble post-COVID syndrome and need to be considered when we see these individuals. And this particular slide is just summarizing what we have talked so far. I'm not going to read the whole thing, but basically this is just a summary of what we have discussed. We've talked about the risk factors. We've talked about for long COVID, we've talked about what is the pathophysiology, what are the symptoms. And now we're going to move into the next part, which is I'm going to quickly go over what are the management and the treatment options available, which is this in green that we're going to be taking up now. So this particular slide just kind of tells us how after an acute infection, majority of the people will actually go on to full recovery, but then there are people who will have persistent symptoms. They might develop some complications, which are early complications, and then some people end up with longer term complications. And in this area, a multidisciplinary approach is very important to recovery of these patients. And this multidisciplinary approach means that it's not just the doctor, but also along with the doctor, there's a whole team of individuals that are important for their care, ranging from a physical therapist, an occupational therapist, a speech therapist, a psychologist, a respiratory therapist, a social worker, and a care manager. So let's talk a little bit about what we can offer in terms of rehabilitation. Of course, some of you might be PT, OT trained and definitely know a lot more than me in that area. But a couple of highlights that I just want to make here, that what we suggest when they come to our clinic is to start with just some light aerobic exercise, which is paced according to an individual's capacity. Now, this exercise difficulty levels are increased very slowly, very gradually until there are improvements in their fatigue and dyspnea, or that is shortness of breath, which we start seeing in about maybe 4 to 6 weeks. Now, breathing exercise are a good place to start if they're not ready for aerobic exercise or light aerobic exercise, in which basically they're trained to use their breathing muscles and diaphragm muscles more efficiently and effectively. That can reduce their work of breathing. You can, once they learn these exercises, they can actually perform these in 5 to 10 minute sessions throughout the day. Again, this is not one rule or one size that fits all, and everything has to be individualized to an individual patient. The other thing is that it's not, like I said, it's not suitable for all, because I've had some people who have not been able to tolerate even this much, but some people have done really well with this approach. Definitely where we don't want to start is when they're already having some high heart rate to begin with, if they're having blood pressure variation, if their saturations, oxygen saturations are not normal, then we probably don't want them to exert themselves at this point too much unless these actually get a little bit, these numbers get a little bit better. In one study, actually about 86%, this is a really high number, people have relapsed following any kind of physical activity. So we have to be very careful and coach them and guide them in a very slow fashion. Now, I'm not going to again read this table, but those of you who are faced with this, maybe the OTPT friends here, they might have this question posed to them in terms of how to return to full physical activity. And, you know, sometimes parents are concerned with their children should go to physical activity fully and etc. And so there's a whole algorithm to this, which talks about how to, you know, have a phased approach to returning to full physical activity. And there you can see the details. You have a phase 1, phase 2, phase 3, phase 4, and phase 5, where you are starting with just some breathing exercises and slowly increasing the intensity up till the person can actually do a lot more and can reach their baseline level. So this is a good article and resource to look at if anybody wants to look at more details. Now, another reason why people come to us is about fatigue, and this is a very common symptom. When they come to us for fatigue, the first thing, of course, is to make sure that we exclude, you know, all of these factors that can contribute to fatigue. It's not always post-COVID syndrome. We have to be careful because these days, a lot of what we see is that everybody gets labeled as having post-COVID if they had COVID a couple of months ago. But we have to be careful that you know, we make sure that it's not some sort of medication that they're on. Are they on too many medications that causing them to be fatigued? Are they just deconditioned and they need little exercise to improve their weakness? Do they have muscle weakness that again needs to be strengthened? Are they having pain problems, sleep problems? If you're not sleeping well, you are going to be fatigued in the day. Are they having some endocrine problems, something wrong with their hormones? Are they having mood problems that are not well controlled that need to be assessed? And that's what's causing their fatigue. So there's a whole list of things that one should be looking at. There is something called as a 4P approach, and that is planning, pacing, prioritizing, and positioning. And that's basically 4 steps to somebody who's dealing with a lot of fatigue. And so how you plan your activities in advance, how you pace yourself that you conserve energy and not use your energy up right in the beginning of the day when you know you're going through a lot of fatigue that gets worse as the day progresses, how you prioritize what needs to be done and you do that first and, you know, use help from your family members and positioning. Again, how you positioning means simple things. For example, if you need to get to that carton of nuts in your kitchen, can I make sure that they are on a lower shelf and they're not at the highest shelf every day when I'm kind of like struggling to reach there and exerting extra energy when I can avoid that? So it's very simple things, but it's called a 4P approach, where we also coach patients about how to, you know, pace, prioritize, and plan their day so that they can actually cope with that fatigue that they're experiencing after COVID. And this particular, if anybody wants to look at a lot, you know, in detail about the 4P approach, this is actually available on the internet. This is a very nice post-COVID-19 patient information pack that I've shared with my patients also, that talks about a lot of these things we just went over, the breathing exercises, the 4P approach, and things like that. And then there are all of these websites that are online that are also sharing exercises and guidance in terms of how to return to physical activity fully after COVID, which is a big, big area for people after they have recovered from the acute illness, especially when they need to go back to work and perform at a certain level. And then finally, the psychosocial support is an extremely important part of their care as well. So many cannot go to work, as I was mentioning, may require long-term government, even financial support. They need coping skills. And then if they're having cognitive dysfunction, which means they're having problems with you know, logic, decision-making, memory, things like that, then, you know, we must make sure that these basic things are at least taken care of, like they're getting good nutrition, hydration, some form of exercises being incorporated in a very slow paced manner. They're, you know, they're able to get some sleep, and then illicit drugs, alcohol, etc., and polypharmacy is being avoided. There's no drug really that we can prescribe to these individuals that can help to completely ameliorate their symptoms, but it is this approach that we just discussed that is going to be helpful. So I'm going to just take a few more minutes to close our discussion or presentation today with this case that I saw in my clinic. This was in May of 2020. And This is a 54-year-old female. She saw me with shortness of breath, on-exertion, chest tightness, wheezing, nocturnal cough, and some elevation in her heart rate. And she says that this was, remember, we had the COVID start in March of 2020. So she said her symptoms had started in March after she had some flu-like symptoms. And as we all remember those days, we didn't have a COVID test that was easily available. And so she never really got the test done, but she had these symptoms months later that continued to persist. So she saw her primary care physician, was sent for a cardiology evaluation that came back negative. And then before she saw me, she was very healthy otherwise, in the sense she just had some little bit of migraine for which she needed some medication. She was having some acid reflux and asthma as a child. She had never had any surgeries. She really had no family history for any lung problems. She was not a smoker, no alcohol or drugs, and she worked as a professor in Hudson Valley. These were the medications that she was on. Her physical exam was pretty unremarkable. So when I saw her in clinic, we decided to pursue a management with a breathing function test as well as a chest X-ray, which came back as normal. We checked for some biomarkers for asthma because these are some labs that we do for individuals who may have symptoms that sound like asthma, which she had, but those labs came back normal. And because she was so symptomatic, we just said, okay, well, let's try this inhaler to see if this would actually help your symptoms. She came back to me a month later and said, well, she did respond a little bit. Her shortness of breath got better, but symptoms were still there. So another inhaler was added. And then finally in July, when she came back for her next follow-up, she's saying she's very concerned because the symptoms are not going away. And it's been so many months. It's almost been a year now. And at that time, we decided to go ahead and get a CT scan of her chest to look for any blood clots. This also came back negative. So it was a pretty normal scan. And we said, well, let's add this medication, which is another medication which we commonly use for asthma. And she comes back at that time in the fall of 2020. And so we go ahead and order that. Next year, symptoms have now significantly improved. Though they're still persistent. So we're now into February of 2021. And at that point, I said, well, why don't we have you see our physical therapy group here? And she also went ahead and went to post-COVID clinic in New York City for a second opinion. So at that point, we are in February. And finally, in September, when she saw me, she said she was 95% better. And we started to de-escalate the therapy by removing these medications that we had her on slowly one by one. And as we speak, she's basically not on any of those, except for one inhaler that she still keeps, but otherwise she's off the other medications that we had started her on. So what did she really have? What was her diagnosis? She never had a positive COVID test, which is, we like to see that, but this is reality. Real life, you may not have a positive test with you when you first see them. So there is a condition called as post-COVID airway hyperreactivity, where the airways are very highly inflamed and patients can have asthma-like symptoms. And I believe that that is what she was manifesting as, and we treated her in that manner with help from our physical therapy colleagues with breathing exercises, giving her time. And a combination of all of these factors, I think, actually helped her to get better, even though it took her more than a year, 1.5 years actually to get better. So a quick word about, we do have we're running out of time. I'm not going to spend too much time, but we do have our post-COVID clinic here, which has certain criteria. This is all going to be in your packet in case somebody wants to look at it. But up until now, we've seen over 900 patients since the clinic opened up in 2022 from 6 different states and 45 New York counties. And we do provide a multidisciplinary approach here in the clinic, along with research options for those who are interested in participating in research. So this is our contact information. And in summary, for today's talk, post-COVID syndrome is a complex syndrome, can involve multiple organ systems. Recognition is very important of this, and initiation of appropriate treatment is important to ensure timely recovery, like was discussed in the case that we just shared. And then large clinical trials are needed to understand the pathophysiology of this disease and to discover new therapeutic strategies. So let me stop here. I thank you for your attention, and I'm happy to take any questions that you might have. Is there anybody who would want to type their question? You could raise your hand. You can type your question. I don't know if
We do.
anybody. Yeah.
We do have one question. Do you treat adverse reaction to COVID-19 vaccine? I have similar symptoms long-term from the vaccine.
You know, that's a great question. You know, this typically would not qualify as the post-COVID diagnosis, right? In the sense, this is from the vaccine and not the actual infection itself. On the contrary, you know, I would say that I've actually seen some people who have felt better, who had post-COVID syndrome, who got the vaccine and who actually felt a little bit better. But then I do know that there are people who've had a reaction to the vaccine and then they did not do well with the vaccine. And this is a very hard area to treat. You know, we don't really know much about it. They can be seen in our office, but I'm wondering if it might be more helpful to see an immunologist, a person who deals more with the immune system of the body, because then this is a reaction of the immune system to a vaccine, and I think they might be able to maybe guide a little bit better.
There's a question in chat. Are there similar post-COVID symptoms in children?
Yes. So again, not being a pediatrician, I don't want to say too much about that field, but I would say that in terms of looking at the literature and what's being published, we're finding that this is actually happening in children also. We were very much aware that this is happening in adults, but now we're finding that even children are suffering from this. So they're not fully free from this problem. And that has a big impact on school life. I mean, it's a big impact on going back to school, big impact on their ability to take exams, to be able to participate in sports. I mean, it's a big thing to be addressed. When is the right time for the children to go back so that they don't feel stressed and overwhelmed? But very important area to be looked at.
We have a question. I have a peer who struggled with significant hair loss and attributed it to long COVID. Have you seen this in any patients?
Unfortunately, yes. So hair loss has been very severe in many people. And it's like, it's not just the hair shedding. They would say that clumps of hair come out, you know, so it's not just like, you know, the regular shedding that you see is a little bit worse or whatever. But I've also seen that over time, it tends to get better. And it, again, how much time is that window? 3 months, could be 6 months, could be a year, depending on everyone. And you know, what can we do? We really can just make sure our diet is as healthy as possible, multivitamins, you know, nutrition, because ultimately that's what is going to allow the inflammation of the body to calm down when we take a diet. Perhaps, again, this is just what I share with my patients. Try to eat antioxidant rich diet, try to eat more green leafy stuff, try to eat more vegetarian stuff, try to stay away from canned preservative rich things, try to stay away from the meats, you know. So I tell my patients to actually try that and give it time, and I've seen that it does tend to get better over time.
Another question is, you showed the photo of the lungs and the white, which I think you said was blood vessels. Does this mean that after COVID, more collateral circulation has developed?
The one that I showed you, and let me just go back if I can, just to make sure that we are talking about the same thing. Yeah, this is the normal slide in which I was saying that some of these are blood vessels. This thing is a normal blood vessel, this right over here. All right, that's normal. So a little bit of white in that black is going to be normal, and that's blood vessels. But when you see all of this, this is not blood vessels. This is actually how pneumonia would look like. This is something that is filling the lungs. There's all this think about it, there's an infection and there's a lot of pus that is being formed. There's a lot of debris, you can say, reaction to that infection. And all of that pus and debris is filling up the air sacs, which are in the lungs. And those on a CT scan look like this, like these white patchy areas. Is that okay? I hope that answers her question, but this is not collateral vessels. This is actually how pneumonia would look like. And this second slide here shows how the scarring, the leftover scarring would look like, even though some of those areas might have shown some improvement, but there's some persistent scarring that can, remain.
She said, thank you, yes. Another question is, in patients who didn't have a positive test, wouldn't antibodies be present indicating infection at some point?
Yes, that is true that, antibodies may be present, but we have to see if were they vaccinated or not. Because if you were vaccinated, you still might have antibodies. And this may not mean that you got the antibodies from infection. It could be from the vaccination also. The second thing to know is that the antibody response is so complex in these individuals that right now, let's say you're only testing for this particular antibody, but and it comes back negative, but then there's so many other antibodies that are also produced that we have no way of testing also. So, you could, and what I'm trying to say is the antibody test is not really a very great test to guide us in terms of who was really infected or not. You can really miss a lot of cases just on the basis of that.
Another question is, what about lung nodules? Can that happen from COVID?
Just from COVID, lung nodules is less common, and it depends again, what are you calling a lung nodule as? Because I really have to look at the picture, but in general, lung nodules are considered as tiny spots in the lungs, which are usually less than 3 centimeters in size. So, that is a little uncommon, but I wouldn't say that it's not possible.
We have a question. What are the standard therapies for long COVID, brain fog, and other cognitive symptoms? How do patients typically respond to these treatments?
Yeah, that's a good question because, so like I said, a lot of this post-COVID management is not fully yet, clear to even the doctors, to be honest. When we have somebody with neurological symptoms, the first and the foremost important thing is I like to, send them first to a neurologist to make sure that they can have a basic evaluation to make sure that we're, sometimes the confusion and the fog, make sure that their brain, coverings are not inflamed. So that means that we get usually an MRI of their brain to make sure the brain's okay. And there's nothing being missed over there. They're not having any kind of stroke. Sometimes I've had people who are having with word finding difficulties, simple words they cannot formulate and say them that they were able to say before. So this could be a part of a stroke manifestation. So the first step would be to go to a neurologist and at least get the basic workup with an MRI brain. And then make sure, a lot of it is time. I think it has to do with time. And like I was saying, the nutrition, the hydration, the rest, the sleep, all of that helps to, diminish this inflammation that's happening at a microscopic level. And gradually the function then will come back.
And a question, do you recommend any holistic treatments like acupuncture or neurofeedback?
These are great questions because sometimes I have had people come to me and share their experience with all of these things. And sometimes people have said it's helped them. I had a lady who swore that the acupuncture was the thing that helped her the most. So, I don't think that there is anything wrong in someone trying to utilize these, modalities of treatment. And if, because I think what you really need is a multidisciplinary approach, just see your doctor, make sure you get the tests, make sure you work on your general health, like we said. And also if you want to use other resources available to you, then that's, I think, appropriate. but not scientifically proven, if that's the question. They haven't been really scientifically proven to be helpful.
We don't have any more questions. Oh, here comes another question. What is the best way to prevent long COVID?
Yeah, so that's a really good question. And I wanted to, one is, of course, there's certain, remember the risk factors slide that we just showed you? Some of the things you really can't change. I mean, for example, your age and the underlying comorbidities you have. I mean, that's something that we can't change. We can definitely make sure we stay in as much good health as possible. Like, for example, if my diabetes, blood pressure, heart, all of that is well managed, well controlled. If we are already tottering on the verge of not being medically optimized, then any kind of insult to the body, whether it's COVID infection or something else, we're going to take a big hit and have problems more than any other normal individual. But some of the things that we also can proactively do, like we know, is that vaccination helps. We know that, there's a medication. I have a slide at the end, which I just didn't talk about it because I wasn't sure that really is relevant, but there's a slide I have just that talks about using the antiviral pill. So this is newer data. This is not for long COVID. So these are acute COVID-19 treatments available for outpatients. We're not talking about this. So people can get monoclonal antibody infusions, which is sort of falling out of favor a little bit at this point. But this pill, which is known as Paxlovid, is the one that is an antiviral pill and can be taken at home. And this drug that is present in the pill has been linked to reduction in long COVID in those who are at risk of developing severe illness. So some of this data is now emerging in terms of what can be useful.
We have a couple more questions. How does COVID affect people with AFib, especially those on metoprolol?
Yeah, it's a real big issue because COVID can, like I was talking about, the POTS, the postural orthostatic tachycardia syndrome. It's a long name, but essentially it basically means that people can develop accelerated heart rate, even at rest, even if they're not doing anything, even if they're not exerting, they're just sitting reading a book, they can feel that heart rate is going up. And it's an extremely uncomfortable sensation. So if you already are somebody who has atrial fibrillation, that means that you would be at a higher chance for perhaps having more of these episodes. But what I've found is that after time, they do tend to subside, but you should definitely see your cardiologist if that is the case.
Another question, have you experienced patients that long-term experience clotting or bleeding disorders?
Yes. We've, when I say long-term, I mean the disease itself has been there for only 2 years, 3 years. So of course we don't have like 10-year follow-up at this time, but have we seen people with blood clots? I would say that's common after COVID.
We don't have any more questions in chat. We've got a few minutes if we've got some last minute questions. I guess I do have one. How would deconditioning, would it present differently than, say, post-exertional malaise? Like, can people do an activity and then they get wiped out after they do it? Do you know what I mean?
Yeah, that's how, a lot of these people have this post-exertional malaise is exactly what they have. That means, and that's why, it takes them a long time. And it's a very small percentage, but I would say, deconditioning is somebody who would respond a little bit to exercise in a more, I would say, appropriate way. You slowly start them to make, slowly start them on a program and they start to get conditioned, they start to feel better, they're responding very well. That's just deconditioning. That means you are in a paced way helping them to get more active and functional, and that works really well. But post-exertional malaise would be different because they actually crash even after doing like a little bit of work. I mean, I had someone who said that I wash my dishes. I need to lay down after I do my putting my dishes in the dishwasher. So that level of activity, and then this is somebody who's young and active, etc. That's not deconditioning. That's something different, and that does take a bit of time to get better.
Here's another question. Do people that attend your clinic need a referral from a primary care doctor?
Not always. You don't. You can actually call our office and get a direct appointment. Is my understanding. Let me just say that these rules change all the time, so please don't hold me about scheduling if I don't, if I'm not accurate.
And I think we have that slide with your contact name.
Yeah,
Yeah, that's great.
And it should be you're going to give it out to everybody, right?
Yes, we can, after you share your slide deck with us, we can send it to everyone who attended today.
Okay.
Just a comment. Thank you for the information presented. We're down to it's 12:56, so I know we do need to start wrapping it up. Another comment, this is wonderful, thank you. Yeah, this was so informative. Please do, take some time to fill out those evaluations. Really, it's super important. We really appreciate that everyone took the time to attend today. Thank you for a wonderful and informative presentation. So, Kelly, do you have anything else to wrap things up that?
No, we will, the evaluation is in the chat box, and we'll send a follow-up email to everyone, which will include the slide deck as well as a link to the evaluation as well. We look forward to hearing your feedback.
Yeah.
And thank you, Dr. Tewari.
Thanks so much, Dr. Tewari. This was great.
Thank you, everyone. Appreciate it.